Thank you very much, Dr. Norris, for joining us, and please begin your presentation.
Right on. Thank you so much for having me. And can you hear me? Thumbs up.
Yes, we can, and I
Okay,
stopped
right on.
sharing, so you're back.
Okay, cool. Yeah. So thank you so much. My name's Johnny Norris, and this is going to be a fun presentation. Like it was mentioned, I'm very passionate about this. It's interesting because it's 7 p.m. my time. This is the time I usually start the bewitching hours, and so my brain is going to probably be firing on all cylinders is when my meds start wearing off. So bear with me. It's going to be fun. It's going to be a ride, but here we are. As it was mentioned, I am a board certified pediatric dentist. I have been described as or accused, really. It's not even described. Sometimes it's an accusation that I'm a public health dentist under the facade of private practice. I've also been accused of being an accidental DSO. As it was mentioned, basically we started to practice in 2018 and we went from 11 patients to just over 36,000 now. And we went from one to, 11 locations, almost 12. And it's very important for you guys to know, like, I'm not PE, I'm not BC. I say accidental DSO, but like, this is all natural. Like this was all organic and it all came from the heart and the urge to just know that there's a different and better way. I started coming out with these messages because I was so convicted on how we need to look at dentistry and reframe the problem. And I knew that I couldn't do it in Florida, for example, because I'm in New England, or I can't do it in Louisiana, or I can't do it in North Dakota. And so I started talking about this, just about 3 years ago, and it's really starting to catch fire. And like I'm really excited because I know you have your own time, you have like friends, family that you're pulling yourself away from to hear this, and I honor that, and I thank you. I hope to live up to your expectations. I think that's why I'm talking about this in a nutshell, is just because I kind of did the thing. I'm a big fan of quotes, and I think Ben Franklin said it the best: "An ounce of prevention is worth a pound of cure." And one of the reasons, like, I'm so passionate about this, and I don't feel like I have to sell anything, is because I see this every single day. The literature is very, very supportive of this, but I live it and I breathe it and I see it and the outcomes all the time. And so, I just feel like I'm a guy, like more than anything, like I know there's some academics here. I know Dr. Catalanato's out here, and it's like, I wouldn't have a career if, these giants didn't publish things before me. And so, again, I love Isaac Newton. He said, if I've seen further, it's by standing on the shoulders of giants. So I'm just doing what researchers and academics have said to do for decades, and I'm just putting it into action. And so, what I learned about all of this, I just ran with it. And like, I'm not really going to go into my origin story tonight. I think that's kind of boring. I've talked about it before if you've heard it. That being said, I think succinctly, I've done this, but professionally, why have we not done it? I call it, it's a Semmelweis reflex. I don't know if any of y'all know who Ignaz Semmelweis is, but basically he's the father of antiseptic procedures. So he's a Vienna physician in the 1850s, and basically he had these cohorts where he saw, one group that was delivering babies and postpartum infection was 18% when the medical students and when the physicians were delivering babies, and he saw that when the nurses were actually delivering, it was 2%. What were they doing differently? They were actually washing their hands. And so all of a sudden, he published these findings and he said, you know what, we should actually, we should actually use antiseptics. We should be doing these sorts of things. And he published his literature. And when he published his literature, instead of being embraced and heralded and said, you know what, you're doing a really great, awesome job, he was completely villainized and completely demonized by the profession. And I think, I was talking with others before we got on here. I think it's because we're all afraid. I think that we've been trained to like look at a problem a specific way. I think that you're going to criticize me. I think that you're going to judge me because, if I do something a different way down the street, you're going to say something bad about me, and you're going to say I'm a lazy dentist, or I'm a bad hygienist, or I'm a bad dental professional. And this is what the Semmelweis reflex is. It's basically saying that we have a tendency to reject new evidence or new knowledge because it contradicts established norms, beliefs, or paradigms. And so I think you probably have all heard of this, but there's actually a timeline, that they talk about innovation. It generally takes about 17 years for a new innovation to take place. And so before widespread adoption is there. And so I'll let you know, even going back from 2017 to now, it's radically different. And so if anybody is like not like getting down on dentistry, this is like my hope for you. I'm just trying to imbue like positivity, because today's a new day, and it's never been a more satisfying time to practice dentistry because you can actually get to the root cause of it. That being said, I have to give you my disclosure statements. I'm the president of my company, Montshire. Montshire, just if you're wondering where Montshire comes from, it's Mont as in Vermont in New Hampshire Shire. So basically the first practice we started was right on the Connecticut River. And I was really I thought it was only gonna be this one practice. and then it just kind of blew up, and it kept going, and we never marketed like until the last year, and it just was word of mouth. And then I just kept doing this and doing this because I realized we were doing something pretty special. And it would be easy to one off a guy that was from rural New Hampshire, and all of a sudden, like, okay, it works in rural New Hampshire, but it doesn't work in, Maine. Well, when I'm in Maine now, it works in Maine. Okay, it works in New Hampshire and Maine, but not now it works in Vermont. Now we do it in Massachusetts, and so I'm at a point where I'm not necessarily looking to expand more because that chip off my shoulder is gone now. However, I'm trying to inspire you and just say, please do it. That being said, I'm also a managing member of Equity Dental in Oregon. I am a National Canberra board member, and I'm also the New Hampshire APD Secretary, Treasurer, and President-elect. The point of all of this is to say is like I'm not representing any of these groups today. I'm just like I'm speaking from the cuff, from my heart, from who I am. And so the big piece to this is the way I practice is very different than I did 3 months ago, it was 6 months ago, 9 months ago, 2 years ago. I mean, there is so many crazy, fun technology and innovations and medicines that are coming out. We owe it to the profession, we owe it to ourselves, we owe it to our patients to stay current. And so I'm just letting you know, like, this is where we are at today. I have a slide that was, just published a month ago. So yeah, my disclosure. Objectives. These are what I was told to talk about. Hopefully I'll accomplish them. Basically, I'm going to be talking about MID, minimally invasive dentistry. So when you see that abbreviation, that's what it is. It's MID. That's what the kids, Gen Z, MID is actually very mediocre. So I always laugh when I see that acronym. I'm a Pete's guy, remember. Number 2 is identify evidence-based strategies that support early detection, risk assessment, and preventative focused care. 3, we're going to evaluate minimally invasive techniques. 4, we're going to briefly explore the role of collaboration between dental and medical professionals. And then lastly, we're going to just talk about ways how you can start implementing this. So minimally invasive dentistry, I told you, like, quotes. This one of the beautiful things is first, do no harm. I can do a whole heck of a lot of damage with a high speed. I can hurt a whole lot of people. If you're a hygienist, you can do a whole lot of harm with a really sharp scaler. But the beauty of minimally invasive dentistry really at its outset is like you're managing the disease and you don't have to hurt people. And I'm not saying that way, like in an offensive way, like when you're doing these sorts of things in the surgeries or the scaling and these sort of like mechanical procedures, we're hurting people. But I do think that we're working with an antiquated cookbook. And so minimally invasive dentistry, the first objective is to define it, right? So let's kick it off. I said this already in a different way, but I do think this is the greatest opportunity in the history of dentistry to do the right thing for the right reason. Time and time again, it's lived out and it's proved out to be a truism in my life. And I think if you adopt this, you'll feel the same and see the same. That being said, like, it's funny that we're talking about this, in 2026, because all of a sudden we're like, oh, this is new, this is innovative. Here's an article from JADA in 1993. And basically here the abstract says treating the disease, not the symptoms, is the change in managing dental caries. As researchers supply the tools, dentists can apply more efficient and realistic methods for better patient care. There's nothing like new under the sun, right? And so they actually say the cutting edge is not the dental burr, right? So that was 1993. Well, let's fast forward now. Where are we at now? So y'all know Dr. Rella Christensen. She basically, Gordon Christensen's wife, she's a microbiologist, PhD, did a publication, like she decades worth of research recently. And this came out last month. And she basically had a great line in this webinar that she just gave. It was about those who were using a drill to control bacteria. And she said, essentially, nobody knows when to stop cutting. And that's because they found highly colonized viable bacteria at the base of 100% tooth preparations, 74 out of 74 teeth. And so even if you can't see it, it's clinically invisible and you can't feel it, it's still there. So what this chart actually shows is you had to go, like, basically when they thought that, or when they did it on a bench top, seeing that, okay, I don't see it, I don't feel it, there's nothing there. You had to go 7 more millimeters before you actually didn't find any microbes. So when we say like we're actually doing this like dental and like drilling and we're actually removing all the bacteria, the question begs itself, are we really? So what is minimally invasive dentistry? Minimally invasive dentistry is, a modern approach to dental care focus, preventing, detecting, and treating dental disease. And it's all about preserving as much healthy tooth structure as possible. So I think that you are all here because you've heard of minimally invasive dentistry, but that's in a nutshell. But if you don't remember anything else about this crazy guy from New England that's just going off the rails right now, I've been talking about this for about 10 months, and I think this is the easiest way for the layperson to understand this. I'm calling it the penicillin moment in dentistry. So in 1928, if you had a simple infection in your digit, in your finger, what would happen is a surgeon would actually cut off your arm. Why? Because otherwise it would prove fatal because it would prove systemic and it would spread. It took about 17 years, as I mentioned earlier, about 19 mid 40s, World War II actually helped kick it off, where all of a sudden surgeons started to trust this little pill. And they said, you know what? I can actually manage this infection by using this instead of cutting off and lopping off people and becoming amputated and et cetera, et cetera. Again, that was like the gold standard back in the day. And I think we're at that exact same inflection point in dentistry right now. And I say 2000, and I call it 2014 because that was when the FDA approved silver diamond fluoride. And I want to be very clear. I do not think that silver diamond fluoride is the end all be all. I don't think it's the panacea. I don't think it's the holy grail. However, I do think it is what kicked off this sort of thinking and therapies and in the collective unconscious of all these different ways to manage a disease. And so it's so incredible now to see the things that are coming out that we can actually get to the root cause of it. So again, this is a really important concept. If you don't forget or remember anything else, this is like, I think the big one. The goals of minimally invasive dentistry, right, is to preserve natural tooth structure. And, I have a fundamental belief that in very rare circumstances and cases, anything that I put in there as a dentist is going to be like superior than your endogenous tissue. Maybe if it's hypoplastic enamel, maybe if like it was, it was enamel defect, maybe you can make that argument. But for the most part, I would argue, your natural tooth, your gums that you're born with are much better than anything else, as a foreign agent or a foreign product or whatever in there could, replace endogenous tissue, like I said. Another thing is like reducing patient discomfort and anxiety. Like that's a real thing. It was mentioned that I was in the Air Force in another life, and I was a dentist in the Air Force. And I can't tell you about once a quarter, you'd have an airman. I was at a high tempo base where we did lots of deployments and you had to do lots of checks before get them air ready before they went overseas to these deployments. And once a quarter, you'd have an airman that went AWOL. And they went AWOL. They were more afraid of coming to the dentist. And I don't think I'm scary like mean dude, but like they were more afraid of going to the dentist than they were to going to war. And I think that's a real thing that we need to recognize and honor and respect that, okay, you know what, the mouth is extremely intimate. It's an honor to be able to go in there and serve and help people in this space. And we need to be careful that we can actually cause anxiety and discomfort, and we can actually traumatize people by what we do, even if we have the best intentions. Another big part of minimally invasive dentistry is lowering treatment costs. When I first started doing this back in 2017 as an associate, I think silver diamond fluoride was being reimbursed like for $4, and they weren't allowing me to do glass ionomer at the same time. And I remember I was an associate, and the practice manager really came after me because he's like, "Yeah, you went from like producing all this money, and you're not doing anything anymore." And so I ended up calling up Medicaid, and I actually started saying, "Well, why are you not paying me?" And they're like, "Well, who are you? What are you doing? Why are you like recommending doing this?" And I said, "Well, there's literature. I'm Johnny. I'm just trying to do the right thing." And to their credit, they asked for the literature, and a week later, they called me back and said, "Keep doing exactly what you're doing." At this point now, they actually reimburse me significantly more than $4. And it's because it's a symbiotic relationship, because they know that, and I'll get to it, I'll show how much money that we save the system by implementing this, and also the outcomes. Gets to the improve long-term health outcomes as well, because I would argue that we're actually getting to the root cause, as I've said ad nauseum, and the etiology of the actual disease versus actually managing the symptoms. And one of the big things that really like gets to my heart is like increasing access, because right now as a pediatric dentist, less than half the kids in the country are going to be seen by a dentist this year. And we are the richest country that's ever existed in the history of like humanity, and it's like this is the best we can do. I love it, but also just because this is what I do in my mouth. This is what I do in my kid's mouth. And I think this is an incredible like opportunity where you invert social norms. And what I mean by that is like normally it's like top down and it funnels from very affluent people. And then it may or may not get to people that are like the have-nots in society. I think how it's been sold for a long time, and I think it's wrong to sell it this way, but I think it's part of the messaging is like, oh, this is like substandard care. It's definitely not substandard care. I think it's the gold standard. However, I think it's getting to people that normally don't have access, and arguably, I actually think they're getting better access or better care because of this inversion of just like where we're at this inflection point. So those are the goals of MID, because otherwise, is this a win or a loss, right? Because like as a dentist, we can be an incredible technician. You go to any like CE event, any of these large conferences, and if you go on the exhibit hall, 90% of what you're going to see is root canals. It's going to be implants. It's going to be crown systems. Talking about disease management isn't like great. It's not like really celebrated. And you know, we can do this. This is technically incredible work. But do we ever stop to think like we're hanging our hat on this because we allow, under our watch, we let a disease completely mutilate and destroy someone's dentition, and then we had to put it all back together? And I would say, is that like a victory? Is that what we should be proud of? Again, I think that we are overwhelmingly positive, good people in dentistry, but I think the time's changing. So, um, I mean, this came out too. You don't want to be like this person. Basically, this was in the New York Times, and they said restoring all of her teeth does nothing to address her susceptibility to her disease, the likelihood of it continuing, and the possibility that her teeth will be lost. So this is not just crazy Johnny talking about these sorts of things. So we were talking about overall health considerations. I know that this is like not interactive, but right now in dentistry, do you guys know what is considered the most prevalent chronic disease affecting humans? Or what is the most prevalent chronic inflammatory disease in humans? Have you ever thought about like how medical and dental, like if you go, like, so I was a history major too in another life. So I always like to go to the deep dive and figure out like why did we end up why we ended up. So the first dental school, 1840 in Maryland, and it was actually there was two guys that approached the medical school and said, "Hey, we're dentists. We want to be a part of you." And the physicians said, "You're not actually real doctors." And so they said, "Don't, you know, like no, we're not going to like integrate you into the training." And so those guys started a dental school right across the street. And that's why that was the beginning of the divide between the mouth not being in the body. That being said, why does this matter? Because dental caries is the most common chronic disease worldwide. That's a messaging problem on us, you know, because you know, if you go out into the public and you say, "Hey, you know what cancer is? You know what heart disease is?" Everybody knows what that is, but nobody knows what caries is. Why do they not know that? It's the most like it's the most prevalent infection in humanity right now. Or periodontal disease is described as the most prevalent chronic inflammatory disease. We're learning more and more about inflammation and immunosuppression, or like these effects downstream on different organ systems. And so much of it can be traced back to inflammation. And so, yeah. And I'm not throwing shade at the profession, but I think we can do better. And I think like we are like at that those that are here right now are at that the tip of the spear and adopting these different ways. And you can see I have like we always talk about type 2 diabetes and gum disease and the poor health associated with heart disease and adverse pregnancy, respiratory disease, and other connections. I think that I was hanging out with Dr. Kessler. He was the past immediate ADA president like a couple months ago, and he said spit's the new blood. And I was like, man, I think you're right. I think that's a whole new area where you can actually start looking for different markers and measure immune response, because we do know that saliva is your defense mechanism against these disease processes. We need to start exploring this. I'm excited. I know it's 7:22. It's fun. So this is like an outcome because it's easy to write me off and say, okay, yeah, this works, but you know, this it might be FQHC. This might be going back to my first slide. I am a private practice provider. I've never turned a kid away because of their financial situations, because quite frankly, I was that kid growing up and I'm not going to do that to anybody. And so I just want to let you know, like as an aggregate, we're roughly about 60% Medicaid. And so if you can make it work in a Medicaid fee for service practice, you can certainly make it in a fee for service model or FQHC or whatever delivery care model that you subscribe to and adopt. You just have to change, different variables. And I don't, I only have whatever 30 more minutes to talk to y'all before questions. I don't have the time to be able to like talk on my different thoughts and ideas on every delivery care system, but it's just a problem to be solved. And I do think it is solvable for every system. What does that look like in practice? Well, so all of a sudden, because you are able to see so many more people and create so much more access, I'm just showing like we just added 11,000 new patients in 1 year. When we talk about these access issues and equitable treatment that should be available to all folks, look at this. It's incredible. So we were wanting to talk about just like different science that backs up what I'm talking about. So again, the crazy guy from New Hampshire has science that backs this up. This is from the ADA. This is their practice clinical guidelines on non-restorative treatments for carious lesions. I did have a conversation with them a couple months ago, and they are all actually talking about re-upping these and revamping this. That being said, because so much has changed since this came out in 2018. But the practical implications, I have it highlighted here, is these approaches have shown to be effective in arresting or reversing carious lesions. Clinicians are encouraged to prioritize use of these interventions based on effectiveness, safety, and feasibility. It's from the ADA, highest level. So This also came out with Canberra in November of 2025. You can see that right there. And basically this goes through, I'm not going to go through all of the protocols, but if you're familiar with ICDOS 10, and if you know about the ADA Caries classification system, knowing how you can actually identify and stage, severity type and extent of lesions, and actually then saying what are the recommendations given the size of the lesion. And so you can see where we have sound initial, moderate, and advanced, and then seeing what surface it actually is on versus occlusal, facial, or proximal. What should you do in these different applications? And this is all based off of science. And this is here for you to be able to come up and say, okay, well, here are the protocols that you can implement, and you should feel like strongly about it because it's backed in science. And it looks like my slide is getting cut off right here. But there's also protocol, and I think I can get you these slides. But basically, it's not just, what we do in the dental clinic. It's also, diet is primacy. It's also talking about biofilm modification, pH, stabilizers, neutralizers as well, supplementation. There's a whole host of different things once we start looking at this as the disease process that it is. Again, this is another decision tree that you can see because I am a pediatric dentist, but I was a general dentist in another life. So I still have a heart for adults as well as kids. And so this just breaks it down as far as, okay, if you have a baby tooth, primary tooth versus a permanent tooth, and if you're looking at how deep the lesion is, what you should consider doing as far as treatments, whether it's selective removal, whether it's the Hall crown technique, I'll get to that in a little bit. ART is a traumatic restorative technique. Sealants, I'll get to that as well. So again, I will not go through all these sorts of things, but you have this for your reference, and please reference the article as well. When we're talking about outcomes and we're talking about hesitancy and anxiety, this is something that I always like to just kind of show is, this was from, through April of 2026, through all of our practices. And I just want to show you our broken percentage rate. When I have a practice of 60% Medicaid, and these are actually pulled straight from our data of almost 36,000 people. So I've got 3.5, 2.1, 3.3, right? And so I know that everyone said, well, folks don't come to my appointment, or they don't know what this is. And I would say we have to look at the person in the mirror, and we have to say, you know what? People vote with their feet. Everybody knows where Walmart is. Everybody knows where McDonald's is. Everybody knows where your dental clinic is. If they're not showing up, it's because they don't perceive value. And we need to give them the value, or we're not honoring, we're not listening, we're not giving them the agency, we're not giving them the voice that they want to be to hear. And so I'm just letting you know, this can happen when you're actually giving and getting to the root cause of the disease. So the third objective I'm cruising through is to evaluate minimally invasive techniques that preserve tooth structure and promote long-term outcomes. I can't see everybody, but silver diamond fluoride. So the two things that saved my career, one was getting into pediatric dentistry. I love adults, but I love peds even more. The second thing was silver diamond fluoride. If you don't know what silver diamond fluoride is, it's basically a chemotherapeutic agent that has the components of silver, which is bacteriostatic, bactericidal. It has diamine, which is basically ammonia. It's a stabilizer, and it has fluoride. So basically, the thing that differentiates SDF from every other medicament, in my opinion, is its substantivity. Basically, everybody gives the knock that it stains teeth black. It only stains where that disease process has happened. But what it does is when you have an acidic insult from a karyogenic bacteria, and you have the demineralization process, it starts to erode the enamel, and the SDF goes in there and actually goes and locks in, and it turns black because the silver changes color, and it remains latent and it stays there. But then in the future, if and when again there's more acidic insult, the silver ions get freed up again, and so it acts twice, and we call it the zombie effect. But again, silver diamond fluoride has changed and has radically changed our practice, and it's cool to see the different things that are coming downstream because this got approved. That being said, it got invented in 1969 in Japan, so we've known about it for a very, 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 very long time. Application of it. I just have a picture of here because if you were wondering how to do this, this is just my preferred method. I know sometimes you'll see in the literature them talking about super floss, those sort of things. You absolutely can do that. I found that you don't need to, in my opinion, clinically, anecdotally, using a micro brush. The most important thing with silver diamond fluoride is you just want to make sure that it's very, 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 very dry, and you get it where you want it. Oftentimes we cover it with fluoride varnish because it allows it to stay there. It doesn't really go and cross-pollinate in places that I don't want it to touch. And it also more fluoride. But there's a picture of how to do it and say it. As far as an outcome, so this is an interesting slide because we did this maybe, oh, gosh, a couple months ago. This is the first practice when I was an associate in 2017 when I started implementing using minimally invasive dentistry. And you can see these dotted lines. You have the SDF, you have the composite, and you have the extractions, right? And you can see back in 2017, that was when I was the first person in that practice that started using silver diamond fluoride. And then you can see that, at 43% of our folks in 2017 had a composite restoration. Fast forward 10 years, it's less than 4% that have a composite restoration. However, 49% actually have been treated with silver diamond fluoride. And so what's ended up happening now is we're able to see more and more kids managing their disease, and we don't have to do these like more invasive, traumatic sort of things. A criticism that's been levied against me is that you do comprehensive care, and I'll say no, absolutely I do comprehensive care. I like basically the only things that I do really at this point are the things that only I can do under my license. Usually it's extractions, traditional filling. It depends if there's dental therapists. Dental therapists can scope of care, so I should nuance that. I don't have any dental therapists yet. Hit me up if you're interested. But yeah, so dental therapy, dental therapists, but the only thing that end up on my books are stainless steel crowns, fillings, and extractions. So yeah. Glass ionomer, again, we've known about this since got invented in 65, but it was commercially available in 1976. The cool thing about glass ionomer is that it chemically bonds to teeth versus micromechanical like resin. It also releases fluoride. And so so in our practices from day one as a medicine first practice, because I do look at glass ionomer as medicine, I would say that we have maybe I don't know what it's called, like a spill or an ampule of composite just for aesthetic things. 99% of what we do is glass ionomer. And glass ionomer, just we do only glass ionomer sealants. And so some other key factors about glass ionomer that differentiates from resin. They're both tooth colored, but they're both radically different. And I think it's very important for us to understand the difference. Because if you ever wondered why resins fail so much, it's because we're putting this material in a very inhospitable environment, your mouth. So if you have your tooth and you have to put bonding agent and you have to put sealant material over the top of it, and you actually use a curing light, it actually pulls towards the curing light, and you actually create a little micro gap, like leak, right? And over time, every bond hydrolyzes. So now you actually have a little spot that harbors bacteria that actually can get in. Whereas with a glass ionomer, we call it the zone of fusion, where it actually chemically bonds to the tooth. And they've done SEM, electron microscopy, and they've done histological slides where they slice it, and you can actually see that it actually becomes one with the tooth. And the other thing about glass ionomer is that it is actually hydrophilic. So it actually only sets up as a chemical reaction in moisture. Guess what's moist? Your mouth. Resin has to be completely desiccated and completely bone dry. So if you're like, why does resin fit? That's why. Why does this work? Well, that's why. So I would argue that it's much easier to place. You have that fluoride release that happens over time, and when you brush it with fluoride, it actually recharges. It's a good option when moisture control, so you can actually do this in outpatient settings or non-clinical settings. So if you want to go to nursing homes or a pediatrician office or anything that you want to do outside of a dental clinic, it works remarkably well. The argument and the criticism, you have lower retention rates compared to resin sealants. This is a pearl that I would give you is always use the polyacrylic acid. That's the cavity conditioner. That's the etch. Never use phosphoric etch with glass ionomer. It actually decimates the matrix and you will not get the ionic bond. So don't use phosphoric acid etch ever. And also the really important thing with this glass ionomer sealants is you don't want to load it too early. So having really good post-op instructions is paramount. You want to make sure that no one has anything hard, crunchy for 48 to 72 hours. So like if a kid's coming in and it's their birthday and they're like, I'm going to be eating chips today, you should probably defer treatment because I can tell you, you're setting it up for failure when you do something like that. That being said, for a very, very long time, we've defined sealant success as can I see it and can I feel it? And I would argue that it's a very poor metric. It should be if it's caries free. And so when I started first doing glass ionomer sealants, I made sure that technique was on point because again, going back to my second slide, I was completely afraid that the guy down the street was going to demonize me. So if you actually follow the technique and you have the same care that you do with resin sealants, your glass ionomer sealants will look like literally like restorations, and they will show up on radiographs, and they sound like glass when you use your Explorer. They are there when you have those acid insults to self-sacrifice, help like remineralize teeth, do glass ionomer. Atraumatic restorative technique. How am I doing on time? Cool. Jo Franken was actually out of the Netherlands and came and basically said like selective caries removal. And we actually then the WHO came out a couple years later and said this should be the first line of treatment for primary teeth worldwide. So basically, we've known for a very, very long time if you do selective caries removal and if you use glass ionomer, you can actually suffocate the bacteria. And because you actually the most important part with glass ionomer, I didn't say this, is making sure that you have a good seal. So you got to make sure that around the preparation or around the margins, it's completely sealed up. Because at that point now you've eliminated the bacteria and you've eliminated the substrate to be able to feed the bacteria. That being said, so much of what we're doing in minimally invasive dentistry uses the concept of ART. If you've ever heard of the SMART technique, silver modified atraumatic restorative technique, that is when you have a carious lesion and you want to actually treat it with silver and glass. Comes from ART. A Hall crown, super interesting. This was, from Norna Hall. Norna Hall was out in Scotland and basically going out into schools. And, this is like caveman dentistry, where didn't have armamentarium and was basically just squirting on and squishing on crowns on non-prepared teeth. And this was using glass ionomer cement. And I know like we were taught, oh, you have to like be concerned about occlusion. That will never work. This is going to be really, really bad. I should update this slide because this is a little bit older slide from a presentation I've done in the past, but there's way more than 5 randomized controlled trials that have shown how it's actually superior. So if you look up all the literature between a Hall crown and a traditional crown, every single one shows that the Hall crown is at least equivalent to the traditional, but there are quite a few studies that show that the Hall crown has better outcomes than the traditional. So from our practice standpoint, we've always so once we knew this, we've adopted Hall crowns. And so a Hall crown basically is a no prep, no numb stainless steel crown. And so this is a sort of situation where, I have on the slide, I have it saying that it's showing a 97% success rate. We are like we're doing publications right now, and I can just tell you internally we have about a 99% success rate with our Hall crowns, and arguably the 1% aren't actually failures because when we do something called a diagnostic Hall crown. And what a diagnostic Hall crown is when there's no clinical evidence radiographically or symptoms of showing a tooth is necrotic or abscessed, but radiographically or clinically it looks close to the nerve, and we have a conversation with a parent and say, you know what, biology is going to diagnose this for us. And we're going to glue this on because first, I'm not going to do any harm because I actually didn't make the abscess. But if this tooth is already, in fact, dead, this is going to hasten and it's going to actually expedite the abscess. Those are the only real times we have any quote unquote failures. Outside of that, they last until they exfoliate and shed. So stainless steel crowns, you have a kit of 48 different sizes crowns. It's basically like an orthodontic band that has a covering on it. And it's, we know that they have much better prognosis than fillings. The only disadvantage and trade-off is that it is silver, not tooth colored. But they're the tooth colored ones. And this is me anecdotally speaking. I don't have anything against zirconia crowns. I'm not trying. The reason that we don't do zirconia crowns in our clinics is because you do have to do surgical preparations, and half the time because they are pre-made and prefabricated, you have to reduce the tooth in all directions circumferentially, so much that it's a flip of the coin whether if you actually end up in the nerve. And then you have to talk about doing the baby root canals and all those sorts of things. And so again, if I'm really trying to exhaust least invasive options first, this fits more in the toolbox and kind of like our philosophy. That being said, if that is a parent's need or wants, we certainly will make a referral to a provider that will give them those services because we want to honor that as well. Going back to agency and meeting people where they are. I think giving people the options. That being said, you don't have to be the person that offers all the options as well. Components of it, really just got to use glass ionomer cement, really. So, and it's going to sound crazy, but you just kind of like stick it on teeth. And I like to share this anecdotally because it sounds so outrageous, but it's been done. I was in Vermont, I think it was 2 years ago, and I saw a kid that had never been to the dentist. He was 4 years old and came in within a 40-minute appointment, did the cleaning, did the radiographs, did all the silver, and I did 8 Hall crowns on this kid without any drilling. I did interproximal slices, but without just some topical jelly, with no Novocaine. I did that all within 40 minutes, and there was no tears, and I got a hug afterwards. And so I share that just because that was literally something that like in other practices would have been like 4 appointments if I had done that and traditionally, or that would have been a general anesthesia case. And so was that kid like a unicorn? Potentially. I think that not every kid would have been able to tolerate that. And I'm sensitive to that. But I do want to give you like the most extreme example that I can give you in that in 40 minutes, the kid that had never been seen before, we were able to do complete disease management in the first appointment. The bite opening, that's always the criticism. The literature says, off by 2 milliliters is not going to be a big deal. I'll let you know the first, again, anecdotally, because it's fun for me to share, or like it's good for you to hear like my failures. And this, I would argue, this is not even a failure. The first time I ever did a hall crown was I was an associate, and a child came in, 7 year old, and I can't remember if it was tooth number B or I, the first primary molars. Frank cavitation, the child had Down syndrome, and this kid was like getting sedated all the time. And I was like, Mom, like I can't, like behavior is not going to render me to be able to like put a crown on that, and I can't get X-rays. And she's like, Johnny, is that like the only thing you can do? And like, at that point, I'd done thousands of stainless steel crowns, but I'd never done a hall crown. And I was just like, well, I could do this technique, but I don't know if like I've never done it before. She's like, can you try it out? And I did it, and I've gotten way more sophisticated since I've done it. However, I opened the kid's mouth by like his bite by at least 5 millimeters, and I didn't sleep. And I called the mom every day for a week because I was only in that office for a week. And like by the time I saw him the following week, was it in complete occlusion? No, but it was pretty darn close. I've never seen the bite change that much, and I'm not saying your results may vary, but I've seen that as well. And so that was an instance where I was able to spare a kid from having to go to the operating room for one restoration because of medical history. Does it work? This is just a publication. I can share this with you. This is actually from our practice. This was over the course of 7 years, over almost 9,000 patients. Basically, what we found was 83% of the kids didn't need anything beyond just using medicine. Of the 17% that actually needed more invasive, when we call it escalation, more invasive treatments, it usually bought us on average about a year and a half. That's really important because now if you stabilize the disease and you have to jump in and do something later, it's very different in the peds clinic when you have a difference between a 4 year old and like a 5.5 year old and the tolerance for these sorts of things. So we've done that. Povidone iodine, we know that's a surgical scrub. Basically, surgeons use it. It's what they use, the orange, liquid, orange rust colored liquid that kills bacteria. It's antifungal. We've known for a very long time that you can use it in your mouth as well. I'm looking at the time. Keep going. You guys hanging with me? Right on. Okay, I told you this is the bewitching hour. So you can see there's even publications back and showing that it actually is selective against cariogenic bacteria. It's really great to pair with fluoride varnish. So basically what we do, like if you have a patient that is aesthetically concerned, in the smile line, I can tell you that I don't ever use silver diamine fluoride just because I think povidone iodine is actually a better option because it doesn't stain. But if you've never used it before, it takes, literally about 20 seconds to put on. You take a Q-tip, paint it on the buccal, facial, labial surfaces of teeth. You don't have to scrub it. It doesn't have much of a flavor. Your teeth turn rust colored for about 2 minutes. It dissipates and it goes away. If you use that a little bit amount, it won't, you don't really taste it. There have been some studies where they show that it doesn't affect your T3, T4 levels. People talk about shellfish allergies. That's a misnomer. It's actually a protein that's associated with shellfish. It's not the iodine. The only real contraindication with using betadine is you have a history of using IV iodine. That in that case, you need to actually do some deeper dive as to allergies or potential issues with it. So also a really important note, don't ever use silver diamine fluoride and betadine on the same tooth at the same visit because they actually counteract each other. Just so you know, this is what it looks like. And so this is a case where, a mom came in and it's like 3 year old, and we just put betadine on there. Did not address her aesthetic concerns. However, I can let you know when you get to the root cause as to what was going on, it's like they were going to bed with a bottle, and you talk about these sorts of things and you get them on, the betadine and the fluoride varnish, and you get them on brush, all the sorts of things that we all know. In very rare circumstances do I actually see this progress. But now all of a sudden, if you can paint these sorts of things on, you can stabilize it. And then maybe in 3 months, maybe in 6 months, you can squirt some glass ionomer on it and then cover it up. And then all of a sudden, those are usually the first teeth that shed around age 6-ish. And now you've done, like I would argue, you've done an incredible service because you haven't had to sedate a kid to fix these teeth. So that's what it looks like. As far as like the cost savings, I did this with my caveman math. Basically, and I'm showing the studies that I used for this, but in 2012, it was about $7,300 for sedation. Using an inflation calculator, I came to, 10,236. And then I looked up how many, sedations there were. And basically, if you look at the range of how much it was, it could save anywhere from $1 to $2.5 billion in sedation costs if we just use the data and the outcomes that I'm having in our practices. Sounds like value. Um, This is just again in our practice as well, showing that when we started using silver diamond fluoride and the reduction in sedation. And we're actually going to be working on publishing more of this and more current. Right now, we've reduced sedation by over 90%. So at this time, this chart shows 74%. But again, using medicine first gets rid of it. So what does this look like with Medicaid and reimbursements? Because I believe Dr. Catalanato said, hey, can you speak to maybe reimbursements and what does this actually look like? So yeah, so last year from silver diamond fluoride, we did, expense. I think we on average we got paid about $13 a tooth. And so you can see, how much with doing this medicine first, you could generate almost $2.8 million by doing medicine. And I would argue that almost none of that was done by doctors. That was actually delegated to the people that like at the highest level that can actually be doing this because I'm better served doing all the surgical things that only I can do and all the training that has like allowed me to do. This is just another kind of like a cost, like just showing how mapping it out. We use Advantage Arrest. Elevate's a sponsor. They didn't pay me to say this. They're not paying me. I just use it because all the science backs. They have all the literature that backs everything up. But basically, mapped it out. 92 cents per drop. Costs $230 per bottle. One drop can treat about 5 teeth. So on the best case scenario, $18,000 generated for a bottle versus $3,700 for a bottle. So again, you can see like how much we've produced with just silver diamond fluoride or stainless steel crowns. Again, in 2025, we did 4,500. How much did we spend on those? All these hall crowns. Again, our return on investment is 3,000. Because we're saving so much time, we have so much efficiency because we can do so many like without numbing, and we basically bundle this disease management as early as we possibly can in that new patient exam. It's oftentimes nobody has to come back for a second appointment. They might have to come back for abscesses and for extractions, and we'll do some more medical management and more minimally invasive dentistries at subsequent appointments. But it's generally only like one more appointment, maybe at most two, and then they're on the recare. And now all of a sudden, once they're on that protocol, it's very rare that we see. You might have a onesie or a twosie that pops up teeth, but for the most part, because you've managed the disease, we just don't see it like burning like it was before. That's a big part of this as well as like putting the fire out, because I think a lot of times in dentistry, we've been trained to like think at the tooth level versus the mouth level, right? And like looking at this as an infection. And if you don't put the fire out, and what I mean by that is like if your house was on fire, wouldn't you put the fire out first before you called the carpenter to build it back? And so often in dentistry, we're letting this fire go on and then we're like putting a crown in their mouth, but there's like rampant decay everywhere else. And if you've not managed that disease everywhere else, it's like I said, it's like building a house while it's still on fire. Got to put the fire out first. Redefining team roles and capacities. So hygienist assistants, RNs, nurse practitioners, doctors, and therapists. That's a big part of how this all works. And so you need to know your practice laws and statutes, and you need to be able to empower people to practice at their highest level. The first person that I've ever hired still works with us, Holly. She's absolutely incredible, and there's a lot of times kids dig her and vibe with her more. To this day, like, can she do a sealant just as good as me? Absolutely. Does it matter that I have alphabet soup after my name and she doesn't? Nope. Because I just care about getting, the best care possible, rendered in the safest, most efficient way possible. And so we need to start leveraging it, because if you look at the data that we have in our clinics, it's not a shortage of dentists that we need. It's just a mismanagement of human resources. So what is this collaboration? So we're exploring the role. So again, I'm getting to the, I'm sorry, guys. See how I'm getting too verbose. Exploring the role of collaboration between dental professionals and medical professionals. So why is it needed? We all know that EHRs are a huge issue. It's a big issue. Like even with our PMSs within dentistry, we don't talk to each other. And so we have these reimbursement systems where we have CPT codes versus the CDT codes. We're not talking to the left hand's not talking to the right hand, and it's like really a missed opportunity for prevention. So where do I see us working together? You have medical professionals going to do health screenings. They should be doing fluoride varnish. Actually, in Maine, there's a CPT code now for silver diamond fluoride. I've actually done education in pediatricians' offices where they can actually do this. I'm actually going to be working with a hospital system in Maine as well, getting them on the betadine train. But they can be doing Caries risk assessment. We can refer, like have an open pathway of referrals. And then from a dental professional standpoint, we should be screened for hypertension because sometimes adults may be seeing the dentist more than they are their physicians, or doing diabetes, or looking for sleep apnea. Airways a huge thing. So again, we should be talking more to each other, and it's very fashionable to say that we should be putting the mouth back in the body. And I don't think there's ever been a better time to be able to do this, because it's really weird that we don't have like that we have dental insurance and we have like medical insurance, but we don't have heart insurance, or we don't have pancreas insurance, or we don't have kidney insurance. And so we finally need to start uniting all of this because this is related to this. The model, basically, how do you pull this off? It's all about doing high volume, minimally invasive care, delegating as much as possible, redefining the roles, which I said. I'll talk about tech real quick and even patient experience. So another big part to all of this is doing teledentistry. Okay, so if you go out to other clinics, so a lot of our clinics sometimes don't have dentists on site, but now because we have teledentistry, we can actually do real-time asynchronous, synchronous or asynchronous screenings and exams. And so now all of a sudden you've been able to leverage, a dentist somewhere else to be able to look at a radiograph real time, or an image real time, right? And so that being said, we use Mouthwatch, and it's for me personally, one of the reasons that it becomes so efficient for what we do is because in peds, 9 out of 10, like emergencies are not an emergency. It's just a tooth that's exfoliating, or it's an ulcer, or something like that. So I can actually, in between patients, look at a picture that was actually sent to us from a parent's iPhone, look at it, see what it is, make a quick note, scheduler can call the parent and say, not a big deal. 1 out of 10 times it is a big deal. And I already know what it is. And as they come in, I can actually do the treatment then. I don't have to bring them in for a screening or a limited oral exam. Same day treatment's completed. Another really big part of this, I touched on it, is just the agency. And so we were taught this in our, professional schools, that we should be giving the RBA, risk benefits alternatives. I'm not sure how many of us actually do this, because at times no treatment is an option, and someone should not be demonized or villainized for that. They need to know the options with that. And I think that at a certain point it becomes monitored neglect, but that needs to be like communicated at times. Just because you can doesn't mean you should. So every one of our patients in our treatment, record, we always go through these different options. And then you just, phase it out based off of the protocols I talked about earlier with the Canberra paper. Again, what does this look like in practice, where you can actually start seeing more people? And so in this example, you can see when we first implemented minimally invasive dentistry in this practice, we grew the practice by over 300% by reducing doctor time by 78%. So right now, well, what does that mean? Like, it's because you can probably tell I've got a lot of energy, and like the worst thing you can do is like not have, like, let me do what I can do. And so if you don't, like, you keep me caged up in like in a place where I can't do anything, it's not good for my head, and it's not good for the staff. So that's why, if you're like, why have I opened so many practices? That's why, because all of a sudden, once we get this population, this disease management stable, there's no operative for me to do. So now if there's no operative for me to do, off to the next one. And so that's why I'm inspiring you, and hopefully, and encouraging you to say, yes, there's absolutely a different workflow and a different way you can think about all these sorts of things. So how do you do it? You just got to do it. You just got to have the convictions. You need to learn it. And people say, like, what do you like? How do you really have to do it? And I think the first place you have to start is the literature. I think you have to convince, I think you have to believe that this is actually legit and real. Because all of a sudden, I don't have to sell a day of dentistry in my life, because people can tell I'm speaking from my heart and from my soul. And they know, like, when I'm recommending something, that it's coming from there. And so, like, when people talk about like fluoride hesitancy or silver diamond fluoride hesitancy, I just don't ever see it, just because I know the science and I know it so well that I can explain it. And all of a sudden people want to do it. So learn the science. And then once you learn it, just implement it, because I can let you know that you are probably way overtrained for these sorts of things from a technical standpoint. And that's also, you have to check the ego at the door, because a lot of the stuff that I did and learned in dental school and in my residencies, I would say 85% of it can be delegated to other people at this point. So I am wrapping up, because I thought it was gonna be 10 minutes, but I'm only giving you 5, so objectives. So we can get the questions. I'll stop.